Hello and welcome to our webinar on pathways to reopen medical schools during the COVID-19 pandemic. I'm Dr. Kate Talen, and this webinar is part of Operation Smile's Rapid Response webinar series. Next slide. Who aren't familiar with Operation Smile, it's a US-based nonprofit that has foundations in developing countries around the world, and for close to 40 years has been improving access to essential surgery through a cleft surgery lens. And during the COVID pandemic, because non-essential surgeries were canceled, Operation Smile has been supporting its almost 100 partner hospitals in 30 countries with donations, with education and training and webinars like this. And so we're glad that you're able to join us. Next slide. So I'm Dr. Kate Talenko. I'm the former director of the U.S. government's Global Health Workforce Project and the former coordinator of the World Bank's Africa Health Workforce Project. And I'm working with Operation Smile to help them with global education and training strategy. Next slide. And so for today's webinar, we're going to have two sets of panels. So the first set will be medical school associations and regulators. And then we'll have a short Q&A and discussion. And so, during the presentations, please in the chat box type in any questions or comments that you have. And then our second panel will be made up of leaders from medical school associations who will give medical student associations who will give the medical student perspective. I'll just briefly introduce all our panelists now, but everyone who's registered will get a copy of this PowerPoint. We'll take a closer look at people's bios then. So our first speaker, who I think might not be able to attend, we'll have to find out, but our first planned speaker was Professor Dr. Olapade Olaupa, who's the chairman of the Association of Medical Schools in Africa. And he's a urologist who's done research in biochemistry, education. He works with the WHO Afro Health Systems Development Research Center, and hopefully he'll be able to join us today. Our second speaker is Professor Dr. Mohi Maghzoub, who's from the Association for Medical Education in the Eastern Mediterranean region. And Dr. Maghzoub is originally from Sudan and is currently the chair of the Medical Education Department at the University of Medicine in the Emirates. Next slide. So they'll be followed by Dr. John Prescott, who's the Chief Academic Officer at the Association of American Medical Colleges. And it's interesting to note that he leads the AAMC's rapid response team. So I'm sure he's been very busy the last few months with that. But he's someone who's worked a great deal with academic hospitals and medical schools to ensure quality training. He will be followed by Professor Dr. David Gordon, who's the president of the World Federation for Medical Education. He just gave a little wave there. And he's the former head of the Association of Medical Schools in Europe, and actually the former dean of the Dean of Medical Faculty in Manchester, England. Next slide. So now we go to our student panelists. We have 3 student panelists. The first to speak will be Ala Dafala, who's the liaison officer for medical education issues at the International Federation of Medical Student Associations. And so she's in her final year at the University of Khartoum. And so she is facing that challenge of how does she graduate if she can't get clinical practica. And it's important to note that the IFMSA represents over 1.3 million medical students worldwide. Dr. Ali Bokhari, who's the president of the American Medical Student Association. Dr. Bokhari has quite a varied background. He's actually worked in the White House, the U.S. Senate, the New York City Mayor's office, and has been involved in political campaigns as well. Next slide. So our last speaker will be Amir Jain, who's director of IT for the Asian Medical Students Association International. And he's a second-year student, and it's quite interesting that his passion is IT. I think increasingly, both with medical education as well as medical practice, artificial intelligence, digital health will be extremely important. And so before our panelists talk, I just want to do a little bit of framing and bring out some important themes. I think as far as a frame to look at issues of how do we reopen medical schools. We know that most clinical practica are closed right now, that students are not having direct contact with patients. We know that some colleges have been able to put the preclinical courses online, but many colleges, especially in low-income countries, have not been able to do that. So I think a framework looking at this, the first is to look at admissions and how this is affecting both the testing, the people having to take admissions tests for medical school, as well as issues of doing interviews and how low-income students are affected by not having access to video conferencing resources. The next part of the frame would be looking at the preclinical classes and how they're affected. That's more of an issue of being able to get online and bandwidth and having the resources to do that. So the third part of the frame would be looking at the clinical practica or clinical internships. This is probably the most challenging issues of how do you keep everyone safe, the students, the professors, the patients, especially during the COVID surges, and often when there's not adequate access to PPE, or if people do get sick, sometimes there's not adequate beds and resources to treat people. And then the final part of the frame would be cross-cutting issues. And these might include issues such as financing. Because COVID is a double pandemic. It's a viral pandemic, but also it's an economic crisis. And we know that many students might not be able to return to school because they might not be able to afford their fees, or they might not be able to afford their room and board. They might have to support their families. And we certainly know that many schools might see their budget cut, either because they're government schools and governments will have to make across the board budget cuts, or because benefactors won't be able to be as generous as they usually are. Other cross-cutting issues might include mental health, might include student assessment, because throughout the life cycle of the student, how do you assess people when you can't be face-to-face or can't be face-to-face as often? Student engagement, student dropouts, how do we prevent that throughout the life cycle? And then I want to bring up 4 themes I think are important. The first theme is that of quality, that we all have a responsibility to ensure that we train and graduate quality physicians who give high quality care to their patients and communities. And how does the COVID pandemic affect that? The second issue is that of service and continuity of the pipeline. If we pause medical education for a year, that means that that country will lack those 100, 200,000 doctors forever, and that will be a permanent gap in sort of the physician workforce in that country. So it's really quite serious when you look at it from that perspective. And so I think at some point there's balancing health risks to students versus the public health risks of having an even worsening physician shortage. The third, and I think perhaps one of the most important themes, is that of equity. I think that both the COVID pandemic and the economic crisis is going to worsen inequity because wealthy schools probably already were online, that they very easily jumped online. Their students can afford high data plan, they have high-speed internet, where schools in low-resource countries, students don't have devices, they don't have laptops, they don't have iPhones, and so that might be a huge challenge, and we potentially see a worsening of inequity. And then the final thing is that of innovation. We really need to use this opportunity to innovate medical education. Areas of innovation that I potentially see, one is regional online courses or online complete curricula. Why is it that 200 medical schools should all design their own, separate online curricula? It seems important to achieve economies of scale or gain public goods that can be shared. Other innovations could include negotiating free or reduced data plans for medical students, so they have improved access to online education. And I think this also will be the golden era of medical simulation, and that this will push medical simulation faster than we've seen it move in the last few decades. In fact, Dr. Magzoub was talking about doing oscopies virtually, so it's a really quite an interesting innovation. And then finally, maybe looking at innovative financing for medical schools to solve some of these financial problems. So those are the 4 areas of themes that I wanted to highlight. And so Dr. Olapade on? Okay, so he hasn't been able to join us, so we will jump to Dr. Magzoub. who will talk about the Eastern Mediterranean region and the medical schools there.
Okay, thank you very much. If you can put the slide, please. Yes. Actually, I'm going to talk about Eastern Mediterranean region response to reopening medical schools. And I'm going to highlight the current experience and how different medical schools in the region respond, and what are the future implications of COVID-19 to medical education in general, and in particularly to the region. Actually, our region is very diverse, with some countries really of high income, for example, of Gulf countries, 6 Gulf countries. And there is also a number of medical schools in the middle income countries group. This including, for example, Egypt, Libya, Morocco, and so on. And then there is the last group is the low income countries, which include countries like Sudan, Somalia, Djibouti, and Yemen. Next slide, please. Yeah, this is the distribution of health worker by burden of disease. You see that our region is including about 10% of burden of disease in the world, but include only 5% of health worker. Compared, for example, to the United States, which have the same burden of disease, but include, for example, 4% of health workers. And we are much better than, for example, Africa, which have the same burden of disease, but 25% of the disease, but only 5% of health workers in the world. So this slide will look at the diversity of distribution of health workers in the world. And next slide, please. So the lockdown actually brought many challenges to medical education. These challenges including, as Dr. Kate said, that importance of timely graduation of physicians to contribute to the health system. And at the same time, really, if we apply any strategy, we have to maintain the quality and accreditation standards. The other problem, which is really the effective how to manage educational crisis effectively, because as educators, really, we don't have classes like this before, so we don't have experience, and we're starting from scratch. And all medical schools really stand the same distance, even in rich or poor countries. Also, we have to ensure that the coverage of competencies and outcomes to graduate safe doctors to the health system. The next group of challenges in the next slide, please. Next one. So we have really to work on availing, this is another challenge, availing required resources. And required resources really is different from one country to another, because the response really, for example, need really well-resourced medical schools, for example, availing high-tech technology to respond to remote teaching and electronic online teaching. And then also at the same time, how to motivate really students and both faculty to respond to this really challenge, because we are doing really preparedness and at the same time implementation, planning, evaluation, all at the same time, so that we need really highly motivated students and faculty to really survive this crisis. And also how to deliver all content of curriculum, because also, for example, whatever technologies that we use might not really cover all competencies in the curriculum. Okay, so the next slide, please. This really how different countries or different medical schools in the region respond to COVID-19 crisis. Actually, most of the countries, particularly in under-resourced countries or group 1 countries, this is group 3 countries, they decided really to close medical schools because students really, they don't have facilities, for example, for computers and also internet connections. So I think medical school, for example, in Sudan, Somalia, and Djibouti and Yemen decided to close the schools, and often, for example, in Syria and so on. Other responses, which include that one, we don't really close the school, but let us bring all as the clinical students, those who want, those who are the time of graduation, so they only allow clinical students. And other schools also decided really to graduate students at this stage prematurely and then compensate later on, and also moving students from one level to another with future remedial interventions. Other medical schools, they decided to continue as normal, but not really, very few of them. And most of schools actually, particularly in war resource countries or high-income countries, decided to use alternative methods like online remote teaching, even of clinical skills, and all curricular content delivered online. And also a number of medical schools used combination of all these interventions. Next slide, please. Actually, this is really from the experience that I'm going to summarize really the effective response strategies which is really adopted and which is the one which is working. I think the really the first step that we have to ensure that we have motivated and committed students. This is really important step, that because really the challenge is so huge and we need highly motivated students and high faculty as well as other stakeholders. And then we have to adopt a response model, which is, for example, the medical emergency response, which include preparedness, response, mitigation, and recovery. This is also one of the models which is used, and also other models has been used. Very important that we have to have leadership to lead the whole crisis, and through involvement of all stakeholders, not only faculty and students, but also our colleagues in the health system and the community. And then also we have to create really a nucleus of active management team to manage the day-to-day activities of the crisis. And then, of course, we have to avail the required resources in terms of internet connections. And if we decide, for example, some medical school remote teaching and so on, telehealth, telemedicine, and so on, this really need high technology and resources. And then faculty development and student training as well is very important strategy. Next, to continue on these strategies in the next slide, please. And also that very important that to have to create clear guidelines, and because this is really, we need complete transformation of the whole system of education. You know, for example, just give example of PBL, we transfer PBL to online in our own medical school, to online delivery, and then we have to have clear guidelines for students, clear guidelines for teachers, and step by step. And also we have to do some modification really on the process. For example, allowing a facilitator to be a chair on a set of students in the traditional PBL system. And then also stress management, everybody really is being stressed, including students and faculty, because really we have a lot of tasks has to be done during the crisis, so that we really have to assure both students and faculty, and also the impact of social distances, and also the psychological problems like any other members of the community. And then also we have to have the close monitoring and follow-up. For example, in our own medical schools, that we have a report after each lecture, and we report the students' response, and also we take their suggestions for further improvement. Effective student assessment tools, this is really important. And here, for example, we have managed even to deliver OSCE online and even clinical OSCE, and all we have conducted a high-stake OSCE for graduation of students are very successful. Evaluation and research, this is also a moment which might not be repeated in the near future. Then we have to make use of it and share experience on research and publication. And regional collaboration, very important. For example, high resource countries has to really ethically have ethical obligation to help poor countries at the regional level. This is important, and we're going to work on that as a region medical student medical association. Next slide, please. Future implication. I think this is my last slide. Yeah, I think COVID-19 really will have long-lasting implications to all our life, including medical education. I'm just going to summarize what are the impact on education for the future. I think for us as medical educators, we have to modify our learning outcome and competencies. We need to include telehealth, telemedicine as one important competence that students really have to acquire. And even to this even in low income countries, because now the technology become very, very cheap and available. And then also crisis management has to be included on our curriculum and in our competencies. And also we have to revise our standards of medical education. Maybe David can have more light on this thing. We need what's the implication to medical education, basic medical education standards. This is important and we have to think about it in the future. Then of course we need to have international and regional collaboration, because really the challenge is the same, the virus is the same, and the symptoms and implications, so that really we have to share experiences internationally, regionally, and at local level, and even at individual medical schools. Of course, we have to produce more health workers. Unfortunately, we have many health workers died. It has to be replaced, definitely. And also demand for more health workers now rising. And with this, there will be actually migration of health workers to richer countries, because now this is really maybe a negative side of it, that now there is a demand for health workers everywhere, and rich countries might really take the health workers from poor countries. For example, now all Germany announced, as Kate told me yesterday, 1 million jobs in Germany. So I think this might really take all health workers in countries. So this we have to make sure this to be tackled in the future. And then medical emergencies also necessitate multidisciplinary collaboration, because now COVID-19 arrived not only as a health problem, as it's mentioned in her introduction, it is an economic problem, it is a social problem, so that we have really go beyond the health sectors to involve other sectors, even like politicians, like economists, like educators, and people in veterinary medicine and so on, so that really we have to have not only interprofessional collaboration, but multi-sectoral collaboration. And this might be also suggestions for accreditation, for example, in future WFME, is that really we have to go beyond health to other sectors. Migration of health workers, this is I mentioned. And the last point really I want to raise, that we have to have now, this is really a positive side of it. Now politicians really are aware that health should be really high on the agenda. Now even rich countries has really exposed severe shortages, for example, in respirators and in equipment to tackle COVID-19, and it now become high on the agenda, and also medical education will be high on the agenda to produce more health workers, so that we have to take this opportunity really to share experience between us, and also at the same time to really have more resources for medical education. So I think this in brief situation in our region, and the implication might be also internationally, not only regionally. And it's really called for more collaboration nationally, regionally, and internationally. Thank you very much.
Great, thank you. As I said, huge challenges, but it's wonderful to see that call for the regional and international cooperation, because I think creating that economy of scale and those public goods is going to make a big difference. So our next speaker is Dr. John Prescott from the Association of American Medical Colleges.
Well, thank you very much, Dr. Telenko, and those folks from Operation Smile who are putting on this conference. And just to reiterate Dr. Maggs' comments, the response strategies that he had out there before, talking about also the future implications. I mean, those are things that are actually truly do go internationally, and there are a lot of similarities to some of the points that I was going to be making. So it's good to see. Next slide, please. The AAMC is an organization that encompasses all 155 U.S. medical schools and 17 Canadian members also. And we have some 90,000 medical students that we work with and represent, as well as faculty and staff and others Really, our mission is to help improve the health of people everywhere, and we do that working with academic medicine. If we can get the next slide too, our medical schools, although this is the topic of this talk is about reopening medical schools. I would just like to explain, in the United States, our medical schools faced incredible challenges as they have across the world. However, we've never really closed. And I make that point only to say that we've had to continue to adapt. We've had the luxury of and the benefits of having some technology that was already in place that we had been using. We had to switch and pivot to be able to utilize them somewhat more effectively. However, and we've actually, had to pull students out of what was the normal circumstances, but the schools themselves actually never closed. And I'll go back over and what we did have to change and how things met. As Dr. Tulenko mentioned, is that at the AAMC, we've had something called the Rapid Response Team. My background is emergency medicine. I tend to think of things in terms of how to respond to a crisis situation, and actually how to prepare for one. And so we've had in place a team that helps coordinate our activities to disasters, but we've never had one that's lasted 4 months. So the COVID-19 has been something that we continue to meet with and respond to. Our group meets 2 to 3 times every week. We do this every day at noontime to look at a variety of issues that are affecting our institutions. We communicate with our federal officials on different aspects as they impact medicine and health across the country. We offer our services to them, our guidance to them, and every once in a while they take a listen to what we have to say, which is very, very helpful. As Dr. Tulenko had mentioned before, there's more to just going to medical school. It's getting into medical school. It's the process of applying to medical school. It's the process of deciding if there's testing that has to be done beforehand, of applying to medical schools, visiting those medical schools. All those things have been turned upside down because of the COVID-19, and we've had to continue to adapt. And so our testing has been, in fact, we're just discussing it this day. A lot of our medical students, most of our medical students take the MCAT examination. Well, we've had to do that now with a shortened examination, one in which people are testing 6 feet away from each other. We actually have 3 sessions of testing a day when we used to only have 1. So we've had to adapt and make things change, but it's amazing when a crisis occurs, how you can think creatively and differently. Same thing has happened with our accreditation services. We've changed and adapted. Instead of having on-site visits, we've had to change to doing things more virtually. Also, this RIT provides regular guidance to our own internal staff, which numbers about 700 individuals, most of them located in the Washington, D.C. area, but many of them are, again, spread out throughout the country. Next slide, please. When we did our guidance for medical schools regarding direct patient care, we had some principles that we thought were incredibly important to follow at all the times. First, we took very seriously Dr. Fauci and other leaders' suggestions that we needed to flatten the curve of infections. And we've been doing that up until recently. And if you've been following anything in the United States, anything we've re-expanded. The curve is not flattening. It's flattening in certain locations in the United States, in New York, up in the Northeast, but in other parts of the country, we have now seen a re-emergence, or I should say an emergence of infection like we've never seen before. But our efforts were to flatten the curve by not having students actually participate in the clinical setting. We also had very much of a shortage of PPE, and we did not have enough COVID-19 testing available throughout the country. These things have been rectified partially. They're not totally there, but I will tell you that the schools in the Northeast, New York City area, Boston, they would tell you that they do have the PPE now. They do have the adequate testing, and they have been able to flatten the curve. Texas, Georgia, Florida, those are states right now we're not seeing that as much. The AAMC did provide guidance to folks, as medical students, at various times, and we've continued to change our guidance when appropriate. So we put out something initially in March 17th. And then had to just, weekly, we changed it a little bit more, tweaked it. And then finally on April 30th, and we have not changed it since then. Our guidance is, again, where it's important that we provide the guidance, And individual schools need to look at their situation with the dean making the final decisions as to what's appropriate for students to do in this particular location at this time. We continue to monitor situations. Great. I'll explain to you what we do have. We have a system in place as part of the supporting the rapid response team that has, it's called ACRES. It's the AAMC COVID response system. When we collect data from all of our medical schools in real time about issues. And so the graph I was going to show you was that more and more medical students are returning more and more school students to the clinical situations. And that has been occurring each week since mid-May. We will probably see a change in that because some of the schools in our southern states are now experiencing more COVID, but we are able to monitor this. And that information is part of a system in which we are able to monitor the impact of this disease. WMC resources. If there's a slide that I would recommend to anyone on this conference is this one for us, for the WMC. On it are two particularly important websites. One is the WMC Resource Hub, which our students, our institutions, but are utilized all the time, but it's free for everyone. It lists a variety of different sources about guidelines regarding medical care, clinical care, research, advocacy, news, media. And then the second thing is the MedEd portal collection, which is really virtual learning resources that anyone can tap into and can maybe assist in helping to meet the needs of our medical students during this time period in which they cannot actually be in a classroom with other folks. It's a MedEd portal is something that's international in focus, and it's international in the resources that it obtains. So it gets them from all over the world. Next slide would be fine. There is a group called the Coalition for Physician Accountability, which is a national group of the major national organizations that have to do with medical education, medical regulation, assessment, and actually licensing. And it's got literally every major organization in there. The WMC works with it. This had been an organization that had been sort of searching for a cause. Well, I'll tell you, the COVID-19 and certainly the response to it has been something that has allowed this group to function and provide additional support on a national level for a variety of different organizations. Last slide, I think, please. Reopening medical schools. Again, a key point in this is that these decisions need to be made locally. Returning to clinical care have to be taken into certainly the principles I talked about before. We've had to make changes to our 2021 application service, as I mentioned before, including the standardized testing. We have had to limit. As a matter of fact, we've had a national, more or less, moratorium on these international rotations, on away rotations for medical schools, except in rare occasions, and then, this is just, again, coming back to Dr. Maggs' comments before, this is going to be a year, it's like anything we've ever had before, but key to it will be compassion, flexibility, perseverance, and that's going to be by institutions as well as by students and faculty and others. And Dr. Tolenko, I'd like to return this back to you and be happy to take questions later on. Thank you.
Great, thank you so much. I'm actually very interested to learn about the Coalition for Physician Accountability. I wasn't familiar with that, but it's good to know that at that high level, all the different groups are interacting. I have heard that medical school applications in the US have surged. You never know when there's a health crisis, whether it's going to drive people away from a field or drive people to the field, but it seems that perhaps in the end, COVID will interest more people in medical careers than discourage them. So our next speaker and our final speaker for this panel is Professor Dr. David Gordon, the president of the World Federation for Medical Education.
Great, thank you very much, Kate, and it's a great pleasure to be here. I have no slides, and I'm just going to make 5 points. Just before I do so, just to say the World Federation for Medical Education, for those who do not know, is the non-state actor that is in official relations with the World Health Organization, concerned with the quality of medical education all around the world. So my 5 points. The first one is that we have been here before. It's a terrible new epidemic, but in the 1850s, Kolkata was devastated. A huge proportion of the population died from smallpox, and medical education and the medical school kept functioning. In the 1890s in Hamburg, again, a huge proportion of the population died from cholera, and yet both medical care and medical education had to continue. And in the great influenza pandemic in the cities where the effects were the worst, Philadelphia, say, again, education continued in some way. So we have been here before, and we have practiced having managed in the past. Incidentally, I should say that we've done a little bit of work on the way in which medical education in general responds very well to crisis. We've particularly looked at the way medical schools are affected by warfare. And medical education actually does rather well in cases of crisis rather than doing badly. The second point is that, of course, medical education is concerned with clinical problems, and we can't go straight through a medical course without exposing the student to those clinical problems and helping him or her to understand them and to be able to manage them. It's absolutely vital that students don't come to the end of a course and then suddenly meet real clinical problems for the first time after they have qualified. So that's an issue that's got to be dealt with. But if our students are going to have the responsibility of dealing with sick people who are dangerously sick, then they need to have the responsibility as soon as it is reasonably possible for them to do so in the course. The third point, and this has been touched on a little bit by the previous speakers, is that maintaining the quality of medical education and managing the assessment of medical students is something that is going to be difficult and may have to be different at the moment. But we have to find ways around it. The only point I would particularly make is that it's very difficult to say that we're going to not touch the issues of assessment, that we're going to go near, not going to go near assessment of clinical competence. We're not going to go near the evaluation of the medical school on the ground. We have to be prepared to find ways around that. The fourth point is to pick up on something that a speaker said yesterday at our own seminar, and he was talking about how it's very important that when students come to the end of the course in present circumstances, that they were safe. And the question I asked him is, did you really mean safe? Because students must not just be safe in the sense that they're protected, they're safe, and they're not going to hurt anybody, but they must be competent as well. In some cultures, there is an idea that medicine is a very dangerous thing and so must be practiced safely, but medicine is intrinsically dangerous. It's so dangerous that eventually all of us die. So our students must be safe, but must be competent at the time they qualify. And however we adjust things, we must make sure that that happens. My fifth main point, and this is one that we talked about at length yesterday, is the way in which you deliver education when students cannot always be in the school all the time. Distance learning, or whatever you wish to call it. And I think this is, the present crisis has exposed a lot of problems that were not very well thought through beforehand. You can't just leave students with a pile of slides and a handout on the internet and say, go and learn something. So distance learning is a much more complicated issue than that. And Janet Grant, who spoke yesterday about this, made the point that we shouldn't be thinking of distance learning as just being done at a distance, but distance learning being a matter of being distributed, whether it's a single student at home working on material on the internet, whether it's a pair of students or a small group working in a distant clinical facility, whether it is a much larger group on a clinical attachment elsewhere. Distance learning is something that has to be thought through and managed very carefully. And it is not a matter of just sending students away, whether to home or elsewhere. It's a matter of distributing the medical school itself. There's no medical school in the world that has a perfectly distributed learning system, but there are those that do have a very good process of that for at least part of their course. The Walter Sisulu Medical School in South Africa, the Bond Medical School in the north of Queensland, and many others. So distributed learning is very important. It's important to manage. At the moment, we're just doing it as an emergency, but I think it needs to be thought through much more systematically. A thing that we are going to do is to develop standards for distance and distributed learning. We already have standards for medical education, which are widely known, and for postgraduate education and other factors, but standards for distributed learning, standards for distance learning are things that I think will be of general and very widespread interest, and I'm sure those participants today who were here yesterday will would endorse that. So those are my 5 main points. We've been here before. It's a clinical subject. We've got to be clinical. We have to think through assessment and quality assurance. We must be not only safe, but competent and safe. And distributed learning is something that we need to understand and do better in future. And we will be developing standards for that. And that's a very high priority for us. But in conclusion, what would I say? I think there are just a couple of points. First of all, it will never be the same again. This is an opportunity to think through what we do to actually make sure that our mechanisms for learning in different settings are improved. It's an opportunity. And I think the next time a pandemic comes around, we will be better prepared. And I think we need to be much better planned for working in a distributed way. So it's an opportunity. It's a dreadful circumstance at the moment, but we've got to work our way through it, and we will do better in the end. Thank you.
Great, thank you so much. I completely agree with you. I think this has the potential to be a pivot point in medical education and other health worker education as well, and that we can talk of medication and medical education before and after COVID, the same way actually in the US, we talk of medical education before and after the Flexner report, that it potentially can have that significant an impact on medical education. So, Dr. Gordon, if you could just briefly define a little bit more detail what you mean by distributed learning for people who might have missed it the first time and might not be as familiar with that term as opposed to online learning or e-learning.
Yes. It's a phrase that my colleague Professor Grant is particularly fond of. And by distributed, it means that it's not only that education is delivered in the medical school and in its immediately associated clinical facilities, but education may be delivered more distantly. But it's not a matter of just sending the education out. It's a matter of distributing the resources of the medical school as well. And if I may give an example from my own experience, I was the dean of a medical school where we taught a very high proportion of the course in primary care, in general practice, as it's called in the UK, in primary care. And we had 300 separate primary care facilities all over the northwest of England that we used. Now that required not just sending students there, it required us making sure that what was there was actually right. So I had a full-time member of staff, a professor of general practice, whose job it was every day to visit the facilities, observe the teaching, look at the facilities that were available, talk to the doctors and nurses and others who were helping deliver the education. So you're distributing just the students, not just the teaching material, but you're distributing the idea and the resources of the medical school itself.
Great, I love that. It seems it's more about getting out of our ivory towers and making sure the medical school goes into every part of the health system and down to the community. We're working on that. We've received a couple of questions, and so I wanted to open the questions up to the Medical School Association panelists. The first question is, we think that COVID is going to increase the demand for health workers, and so as Dr. Mahzoub said, there might be this increased migration of health workers. What can medical schools in every region do to either in the what's often called the sending countries to increase retention in those countries, and in what's often called receiving countries to scale up medical education there so that we don't need additional physicians, because it's sort of this divided responsibility. So if anyone on the panel would like to address that issue.
Thank you for asking us an easy question. This is a continuing and ongoing problem, and I think it requires countries, whether the ones that receive healthcare workers from elsewhere or the ones that send them, to work together responsibly and in a collaborative way. We're not going to stop doctors and other healthcare workers from moving. I mean, doctors are one of the most mobile professions in the world, and and that's not a bad thing. People travel, gain extra experience, but there must be a culture where people don't just think through why they're going and whether they're going for more money or safer facilities, but what they can do with what they gain elsewhere. Our colleague, Professor Olubunmi, whose picture is on my screen, but he doesn't seem to be here, is a perfect example. He did some of his higher training in surgery in the UK. He was an attending surgeon in a major faculty in the United States, and he's taken that skill and experience back to Nigeria, hugely to the benefit not just of medical students and medical education and medical care in Nigeria, but more widely in Africa.
Great, thank you.
Yeah,
Dr. Muslim.
Oh, yeah, I think this is a very important issue, and as I have mentioned, that the migration of health workers to might increase because of high demand of doctors in host countries for migrants. And I think we cannot stop this, as Dr. David said, but I think we have to see other strategies, really, how those migrants come back to their own countries and how to really transfer brain drain to brain gain. In this format, I think even with the available technology and becoming very cheap, that migrants, health workers, they can help their home countries, through telehealth, telemedicine, contribute to to their home countries. The other thing which is really even raised at really the European Parliament, which is how host countries can pay back really, because the training of health workers is so expensive. For example, a health worker or a doctor might have $1 million a year. That is the cost of training, and this really very huge. And also migrant doctors at the home country, this is really for research, that will lose at least $1 million a year, and 3 mortality as the migration of one health worker. So it's really great cost to to source countries. And I think there is ethical obligation for host countries really to pay back for the health workers who are really working with them, not really to pay the health worker himself, but also to pay the back for the cost of education and so on. And this really could be not in a form of direct, but also could be also indirect help, for example, like contributing to improvement in medical education, to also available in telehealth and telemedicine, training doctors in home countries and so on. Like what we are doing now here is this, and also raising awareness of this important issue. And I think this might be strategies that can help. Thank you.
Thank you. So that's a financing solution that receiving countries potentially pay for the medical education of the physicians that they receive. And I'm certainly familiar with a number of medical students that have as their stated mission training physicians for the local community, and that how they screen the applicants in every aspect of their training is to incentivize them to stay in the country and serve those communities. Dr. Prescott, did you want to answer that question as well?
I can add a quick comment on it. Since 2008, we've actually increased the number of medical students in the United States who are U.S. citizens by 30%. And because we did recognize that we have a need, and we also recognize the points that others have made so far. I think we've seen some decrease in the number of international medical graduates coming to the United States, but I wouldn't say we certainly haven't stemmed that tide. And I think that there's a larger issues that everyone has brought forth right now. But again, we've went from 125 medical schools to 155, and again increased not only the number of schools but the size of most of those schools, trying to meet the need with U.S. students rather than having international medical graduates come in. But it's an incredibly important issue.
Right. So pursuing that self-sufficiency in training physicians. Fantastic. So we'll start now on the student panel. So if the association speakers could turn off their video camera so that we can see the student speakers.
Sure. Thank you so much, Dr. Tlenko, and thank you so much to Operations Mod for the opportunity to speak here. I think I have a lot of similar themes here that have been discussed already, especially with some of the conversations we're having from the AMC front. I think, you know, a couple of weeks ago, Dr. Atul Gawande talked about how history has called on medical students at times of need before. In the pandemic of 1918, medical schools graduated students early to join wards where staff had been sent to overseas, and during World War II, accelerated medical school education pathways were condensed to 3-year pathways so that medical students could serve. And this pandemic is another such moment. I think one of the best traits of medical students has been that they think about helping their communities and their patients before they think about themselves. And it's that attitude that has driven medical students around the country to find ways to help combat the pandemic within the United States through any means at their disposal, including from collecting and making PPE to setting up the COVID Service Corps to graduating early and joining the front lines. We couldn't be more proud of the efforts our colleagues have made. And much like this pandemic has brought attention to underlying issues within our U.S. healthcare system, so too does it highlight both the adaptability and the limitations of medical education. Schools around the country have had to make emergency curricular changes, which in the clinical years have generally led to the cancellation of clinical components of rotations. Most schools are continuing to keep clerkships going, with clinical components replaced by remote didactics and volunteer type work. And for both the non-clinical and clinical years, licensing exam schedules were disrupted. And for some of them, like the practical portion of the USMLE, they were waived for the near future. So this it leaves a larger question, right, that we're discussing here. What will this do to medical education? Another pressing question is, what can we learn from the last few months in preparation for surges, additional waves, future pandemics, and the broader changes to medical education in the long term? The medical school administrators and the medical education regulatory complex have generated guidelines and are continuing to provide guidelines and solutions. And there are a few principles that we can work off of. The first is medical student protections. This includes COVID testing for students on a regular basis in clinical settings and ensuring access to PPE. Second is flexibility for the incoming generations of physicians. While the accreditation and assessment criteria for U.S. medical schools is standardized, the medical student experience is not. And those disparities in experience for broader medical education are especially highlighted right now. There already has been movement on this front, including making classes pass-fail, waiving the USMLE Step 2 CS, delaying the match application, and I think some discussions on including a portion on residency applications to detail the impact of COVID on applicants. Much like these are not normal times, so too we cannot afford to evaluate incoming generations of physicians as we would during normal times. And this calls for equity in assessments so that the incoming generation of physicians is adequately equipped to serve patients. Third is ensuring quality training and equity in training, especially when in-person training may not be feasible. So this includes the virtual experiences with real patients, the upgraded clinical simulation training, and ensuring foundational and procedural skills for fourth years who are preparing for residency. And lastly, is to raise the level of participation for medical students as part of the Roger Hart's ladder of participation from medical school campuses all the way to the medical accreditory and regulatory bodies. Many of these bodies, including here with Dr. Prescott, with the AAMC, have student representation, and we appreciate their efforts to incorporate the medical student voice. In line with that, the broader theme we're aiming for is to ensure that as the community of medical students are critical stakeholders who can engage directly and effectively so that decisions are made at the table with them. And these are just some broader principles, and there are so many more, including some that we touched upon earlier today, the mental health of medical students, not just from distance learning or disruptions to their training, but also the compounding effects of looking out for the safety of their friends and family and being surrounded by death, and along with experiences volunteering on the front lines for some of the early graduates in 4th years and 3rd years. So here with the American Medical Student Association, as the largest independent American Medical Student Association, we've been part of working groups, especially with other medical student associations, holding COVID series where we're continuing to have discussions with decision makers, and we'll continue to engage with medical students so that we can elevate their experiences and channel them as we are providing input for what's happening on the ground. And not just in the midst of this pandemic, but to ensure the necessary engagement during this pivotal moment for the broader evolution for medical education. I'll hand it back to you, Dr. Dolenko.
So now we'll have Samavir Jain from the Asian Medical Students Association.
Thank you, Dr. Dolenko and Operations Smart for giving me a golden opportunity to share my valuable views on pathways to reopen medical schools in current COVID scenario. So, first of all, directly jumping into the topic, I would like to discuss a few points about the status of COVID-19 in India and the curriculum which is followed in India. This is just a refresh our memory with some general data about the virus compared to the India and worldwide data. Worldwide, there are about 9 million cases worldwide as compared to India, which have 400,000 cases in India. So next slide. This is the graph which shows the progress of total number of cases in India per day, and it has reached about like 14,000 cases per day. And India stands at about 4th position in terms of total number of coronavirus cases in India, in the world. So next slide, please. Yeah, this is the brief introduction about the lockdown in India, how the lockdown has started. That is on 24th March, the Narendra Modi declared, the Prime Minister declared the nationwide lockdown for 21 days. And after that, it was again extended till 3rd May. And on 1st May, again extended for two weeks. And on 17th May, it was again extended till 31st May. And from the 1st June, it was again extended for a month, but opening majority of economic activities. Yeah, this is the brief introduction about the curriculum of medical schools in India. In India, our UG medical course is like MBBS is of 4.5 years plus 1 year of compulsory training internship. And the table shows the subject-wise distribution of the professional years, and the minimum of 75% attendance is mandatory for all the students to sit in the final examinations in their prof examinations. In India have coped out with the crisis. The classes have been suspended to prevent gathering. Clinical rotations have been suspended. All the students have been advised to move to their homes and to vacate the hostels. And the duties of interns have been increased to help the facility with COVID-19 outbreak. And the mode of classes have been shifted from offline to online mode through Zoom, Google Meet, etc. So next slide, please. These measures need to be continued till the pandemic is over. Yeah, we can't expect the normal life until this pandemic will come to an end anytime soon, or we have the proper medications for its cure. The graph shows the normal timeline for the development of vaccines, and if we faster the process, it will take another 1 year for the development. So the medical schools will go online for this particular period of time. So I think an online education can't be replaced, because the online education can't provide the hands-on clinical experience on actual patients, and the practicals like the dissection of cadavers, hematology, microbiology can't be done. But what is the? I would like to discuss about the current scenario of medical education in India in just a brief. You can say the online education has become a lot hectic for medical students in India. It is just the shift of college hours to online hours. what are the problems we are actually facing with online education is that we don't have the blackboard or handwritten teaching of concepts as due to the lack of infrastructure and tech savvy, you can say, professors. And the total screen time has been increased a lot, that is 5 to 6 hours of online classes every day, and moving faster with the syllabus and covering the syllabus every day which was taught that day. And I think there is no companion and talk and meet and all the, and this is the famous saying like all work and no play makes Jack a dull boy, is actually affecting the medical students and eventually decreasing their outputs. So I think, and there's also point to mention that there is proper connectivity issue in India, as most of some of the students don't even have the proper connectivity. So need to open the medical schools, but how? I would like to strategize it into two parts, like for preclinical students as well as for the clinical students. Next slide, please. Yeah, for the preclinical students, I would like that the theoretical classes should be conducted from their homes or from their hostel rooms, or that the batch of 50 students should be conducted with proper distancing in the lecture theaters by encouraging morning and evening sessions. And what will be the measures we should take in hostels? Like students should be tested regularly for the COVID-19 screening tests, such as temperature checking should be encouraged every day by the hostel authorities, and proper sanitation should be encouraged, and the groups of 5 to 10 depending upon, practice should be conducted in the groups of 5 to 10 depending upon the strength of the batch. So the next slide, please. This is just the hypothetical schedule made by me only. If we mark the 3 days only for the practical and the batch of 100 students, and the numbers show the roll numbers of them. Yeah. For the clinical students, the similar strategies for theoretical and practical schedules should be followed. And for the clinical rotations, I would suggest the university should set up non-COVID facilities where the patients after screening and tests for COVID should be brought there and examined by the students. And the group of not more than 5 students should be encouraged, and masks should be made compulsory while entering the facility. PPE kits should be encouraged. I would like to discuss this point further in my slides. Should PPE kits be encouraged or not? And the proper sanitation of non-COVID facility and ensuring proper distancing. Simulation. I heard a lot of online simulation platforms like Medscape and Body Interact, which provide a very good platform to enhance the clinical knowledge, as well as with their powerful softwares which are designed to monitor each and every progress while solving a case. So some of them also provides group solving of the cases, and I think it can be implemented during the COVID-19 pandemic, but not a replacement. Next slide. I have further discussed this in my next slide. Yeah. Online simulation replacement for clinical rotations. I believe it is it helps you to develop the clinical knowledge and approach to various complicated cases, but the clinical experience like use of stethoscopes, listening to various murmurs and heart sounds, measuring BP, how to use ventilators, how to take history efficiently in vernacular language can only be developed by interacting with live patients. Next slide. I have mentioned earlier that PPE should be encouraged or not. I believe the PPE kits should be dependent upon the type of region. I believe the region where I live suffers the summer temperatures of like 45 degrees Celsius. And I believe how can we wear PPE kits since most of the colleges are not fully air conditioned. And I think I have heard many cases of doctors and students getting painted due to so much intense heat and sweat from these kits. And I think demand has increased many folds, and therefore the prices have been increased by many folds. So I believe by the private colleges will invest so much money on the students to provide the PPE kits, since they are not getting any subsidies from the government. So I believe it should be we should not encourage the PPE kits in the non-COVID facilities. So examinations, I think more projects and assignments should be conducted on online groups. Online simulation are a better way to evaluate, and multiple choice questions should be, examination should be conducted within limited time, and open books examination should be encouraged. Since the pandemic is there, we can't expect the offline mode of examinations. So next slide, please. Yeah, this I want to mention in my slides that university fests and sports and athletic meets. I think due to this COVID-19, until it prevails, we can't expect the fest to take place as to prevent the social gathering as well as to maintain the social maintenance norms. So you can say the reports says that 45% of the adults will have their mental facts affected, and out of these, 19% of the adults suffer a major impact on the mental health. Like various organized online and innovative competitions have evolved to make up for these quests, and our organization has recently conducted the innovative cultural and academic exchanges. Most recently is the PRI-AMZEP, the virtual exchange program between the three countries like Malaysia, India, and Thailand. Our chapter AMSA Indonesia also conducted intensive, which brought and connected so many international delegates around the world and around Asia. I certainly believe that I am very good in sports. I believe the sports fair should not be ignored, as it plays a very important role in mental health as well. So sports which involve small teams should be encouraged, I believe. I want to discuss this academic 2020 session. I want to brought about the plight of the students which are yet to give their entrance examination and to enter their medical colleges. Like in India, we have a medical entrance examination which was going to be conducted on May 5th, but due to the COVID-19 pandemic, it was postponed till the last week of July, and it was again postponed as because of the increase in the number of cases in India, but day by day. And it is also conducted on offline mode, so students are literally depressed and unsure about the future, and as they have worked very hard in preparing the examination. So next slide, please. So in next slide, I have shown the three major questions, like will academic session 2020 will consider a null year, and how will the academic session 2020 will proceed, and would it lead to a new examination pattern? And I am still unsure about these questions because it depends upon the government policies and innovative ideas they brought for the benefit of the students. So I believe this should be considered, these three questions should be considered, will there be or not. So positive aspects of COVID-19, I believe the COVID-19 has brought the importance of the family time, judicious use of resources, non-polluted environment, and opportunities for college to prepare for such pandemics in future. And next slide, please. Yeah, this is a quote for all the professors, not only my professor, for all the professors, that they are trying their level best to teach us through very limited resources and having less knowledge of technology. So next slide, please. Yeah, these are some of the questions which were asked in the Twitter chat session, which was conducted in 2 weeks earlier. So I will quickly go through the answers for the important questions. Next slide. Yeah, how the COVID-19 has affected medical education, like classes have been shifted from offline to online mode through Zoom, Google Meet, etc., and clinical operations have been suspended. And how do you think it will permanently affect it? I think it should not be implemented because the online education can't replace the clinical experience, knowledge, and practicals. Next slide. Yeah. How do you think the preclinical will look like in new academic year? As already discussed, the strategical plan to open the medical schools for preclinicals, I think it should be the mix of online and face-to-face with mask mandatory. So the status of clerkships, like it is limited up to the interns, while it is posed for all the clinical batches. In some state, it is limited to final year students as well. Next slide, please. Next slide. Yeah. I would like to mention some of the financial challenges which the medical schools and students are facing due to COVID-19. Like medical schools are facing the lack of infrastructure and tech-savvy staff to conduct the online classes, and as well as the unavailability of the organization which provides such infrastructure. And the students, like proper devices and the lack of proper internet connection is making a great problem. I believe the government should come up with innovative policies to help such institutions, and moreover, various big organizations like Google is extending its sports for free for education institutions. So next slide. If that is over, that is the quote which I like the most. Ultimately, the greatest lesson that the COVID-19 can teach humanity is we all are in this together. So that's all. Next slide, please.
Well, thank you so much. I certainly hope that 2020 isn't declared a null year in medical education for clinical education. That's a frightening thought. It looks like we now have Ala Dafala with us from the International Federation of Medical Student Associations. Please, the floor is yours.
Thank you so much, everyone, and I'm extremely sorry for the technical difficulties. I actually hope that you can hear me well, and I hope that you can see my slides as well. Okay, perfect. So, like Kate Bradley introduced me, my name is Ala Dafala. I'm from the International Federation of Medical School Associations, and I'll be giving you the take of medical students from a global perspective towards reopening of medical schools during COVID pandemic, because as we seem to all agree, COVID does not look like it would be going soon. Next. Perfect. So the first slide that I want to share with you is that earlier January this year, it was announced that COVID-19 would possibly be a pandemic. And then later on towards March, it was definitely announced to be a pandemic. And since then, a lot of people have been impacted, and so has medical education. Next slide, please. When it comes to IFMSA, what we did is we launched a COVID medical education tracker to look at the countries or how medical schools and medical education has been impacted around the world. Before sharing the results of those trackers, I would like to share with you, first of all, the situation of countries when it comes to the cases and the number of COVID. And then we can see that the European region and Northern America, as well as the Americas, have been having more stricter policy stringencies and, of course, complete closure of their borders. Next. Perfect. So the next slide will show some of the results that we have been having based on our COVID tracker that managed to collect 3,000 responses so far, actually 3,040 responses from various medical schools around the world. And in total, we have 3,040 responses from 103 countries, and only 2,600 of those medical schools, actually a lot, 2,600 from those medical schools had a complete suspension of their education, and only 147 medical schools are still functioning. And by functioning, we mean that schools have not interrupted their educational classes or their clinical trainings of their students. Converted to percentages, we're looking at percent of the schools that have responded have come to a complete suspension. Asked medical students furthermore to reflect on how the schools were dealing or how they were responding with the COVID-19 pandemic. And 12% of students said that their schools had no plans at all. 13% happened to be in the process of planning an alternative to education. 18% have had some classes being restored online, but no progress on others. And 50% of schools had some online conversion of their classes. Now, I would like to share that there's a great disparity between regions when it comes to this. So we noticed, although I have not shown it here, that most of the from European and American regions had responded yes to having an alternative plan to their education. But when we look at regions such as Asia, Pacific, Africa, and generally the global south, then there has not been any progress with regards to education. Important, which is the point of equity in access to education amidst COVID-19 pandemic. Now,
I can't hear her. Perhaps we've lost her. Well, hopefully she'll be able to come back on and continue her presentation. So, but let's go on. We've had some questions about deferring medical school, or and I'd love to hear panelists' thoughts on that, and people in the first panel as well, if you want to chime in. Are medical schools allowing students to either defer entry into first year, or maybe they're a third-year student and having them wait until they do their fourth year? What are people's thoughts on deferring?
Sure, I guess I can speak just a little bit. I think this is an area that's been especially brought up for the third year or second year medical students here. Generally, the principle of deferring medical education, especially from second year going to third year, third to fourth, has been common, usually for the purposes of taking on a research year or taking on additional academic degrees. I don't have numbers of how much of this is taking place, especially with the impacts of the pandemic, but generally there has been a sentiment amongst certain population to take advantage of flexibility as things are being ironed out. Generally, from what we've been hearing from medical students on the ground, fortunately, we have heard that on a case-by-case basis, depending on the individual guidelines of different medical schools, there has been flexibility for students being able to take a year to pursue other opportunities during their medical education careers. I think from a broader standardized approach, I'm not sure if there are official guidelines allowing for that flexibility, but just going off of the status quo of students taking that pathway traditionally, that's what's been in play.
I see that all the follows back.
Yes.
Perfect. Well, okay.
Perfect. I hope you can hear me well, and I do really apologize for this technical issues. But like I was saying, it seems to be that there's no one way towards reopening of medical schools, because there is no one situation or global status of medical schools around the world. Different regions are at different places. However, we have 4 key messages that I think are very important. Now, the first is there is a clear need to a transition to distributed learning and somewhat some forms of e-learning. However, we need to acknowledge again that infrastructure is a very limiting aspect to how schools can adapt and reopen, and hence we do need to call for more collaborations between universities and between sectors to allow for a smooth transition, at least into the necessary infrastructure it requires. The second point is the education content itself. I think COVID-19 pandemic has shown that we need to make sure health workers do have the competencies to tackle such a pandemic, and not only from the knowledge aspect of things, but also in terms of ethical training. And we see that a lot of doctors have been put in situations where a sound knowledge of ethics and a sound grasp of those principles is needed. So we do need to rethink adapting education to make sure that future healthcare workers are prepared enough to tackle this pandemic. Next slide, please. The next slide is on student safety, and we actually did analyze through our medical education tracker the involvement of medical students so far in healthcare facilities, and we noticed that a large percentage of students either functioned in the outpatient medical units or emergency units, and this places them at the front lines of fighting off the pandemic. And so we had a follow-up question on the next slide, and we asked students whether they were offered any form of personal protection or any support through PPE or things like that. And as you will see on the results in the slide, that a lot of responses showed that not applicable. So the blue lines are the ones that are the highest. At least for hygiene protocol, we had somewhat positive results, but especially for gloves, medical masks, protective glasses, and disposable gowns, the most of the responses that showed that students were not actually provided with the necessary equipment to protect themselves. And this raises the question, even if we are to go back to clinical training, which is paramount, are we ready, or do we have enough resources to ensure that students are safe and even constantly tested to ensure that they are not at risk? The third point would be on students and mental health, and it's actually on the next slide, please. Whilst mental health, when it comes to students, is quite different from physicians and mental health, however, they interlink a lot. We know for a fact that the impact of COVID-19 on education and its suspension has got significant impact on mental health of students, as well as continuity of education. However, we also know that a lot of the young doctors or recent graduates, who we can also assume are final year medical students, have been experiencing a lot of burden when it comes to mental health. And so we need to rethink whether schools, if at all they will be opening, have enough support systems in place to ensure that students, final year graduates, and people practicing in clinical settings have the adequate mental health support to ensure that they are not a harm to themselves before not being a harm to others. So this is the third point. The fourth and the final point on the next slide, please, is students and financial security. Needless to say, COVID-19 has got immense economic impacts, and that also extends to the educational sector. And I think we need to study furthermore the financial implications of the pandemic on working students who are now unable to work, unable to secure an income, and hence unable to pay for their education, or actually have already paid for their education, but are unable to receive the education that they paid for. We also need to consider foreign students. A large number of students, especially in the medical field or in health professions education, study in countries that are not originally their home countries, and the situation around financing and sustaining their education in these countries is quite difficult. So before we even rethink or question reopening of medical schools, it needs to be thought about how we can ensure financial security of students. COVID-19 has put many students and financial and educational futures in jeopardy, and we hope that before we question the reopening of schools or actually start implementing it, that at least these four paramount factors are put into concern. That is my final slide, and I hope that I was able to clearly send the message. And once again, apologies for the technical difficulties.
Great, thank you so much, Ala. We only have a few minutes left. I was wondering if any of the panelists would address some of the issues of access to internet. Some solutions have been mentioned, internet cafes, negotiating with telecoms. If people want to discuss other ways that people can access internet or access devices.
Hey, this is John Prescott. I'm sorry, Dr. Lutonko. This is John Prescott. My quick comment on the access to internet. I know probably the biggest challenge we had with Hurricane Maria in our schools, 4 schools in Puerto Rico, was a total shutdown, and that was incredibly difficult. And so actually, it was, I think someone brought in one of those blimps that actually was able to allow for a cell tower, to allow for some internet, to allow for some connections. But you're correct. In dealing with situations in which there is no capability, many of the solutions that are that we can utilize in some of the countries will not be applicable in many others, and it's an unfortunate reality.
Great, well, thank you so much. And with that, I think we'll need to wrap it up. I want to thank everyone for participating. Thank all the panelists for their fantastic presentations. This is an issue that we will continue to work on. Look forward to working with you on it. Everyone have a fantastic day. Take care.
Thank you. Goodbye.
Thank you. Goodbye.
Bye. Thank you.
Thank you.